It's always nice to acknowledge and the appreciation for coming out here. It was a pretty easy ask. Number one, it's NIH. It's where I spent a little bit of time when I was in residency here at George Washington University. Two, this is where I'm from, so it's always nice to come see Grandma. So this is the last time you'll see that picture. That's the look my residents say I give them when I don't believe them. And I didn't realize that until I did it. So it's gone. I got one with a tie. I'll tell one quick funny story. We used to do, as George Washington Neurosurgery residents, we would come up here and our grand rounds, which is our way of getting together and sharing ideas, was we would come up to NIH on Tuesdays. So we take the metro up, come up that long escalator, sit in a room and talk about different neuroscience ideas. So we sit in the room and this guy is, it comes in, he's going to give a lecture on one of the basic science topics, and his slides weren't up, right? So slides weren't up, and he says, well, I'm going to go ahead and go to the bathroom. All right, so he goes to the bathroom, and everybody's waiting for him. The slides come up, and this guy's, where's the guy? And you hear zip, and then you hear, and then we say, what was that? And you say, and you hear, flush. He forgot to take his mic off. Right? So we're sitting in there the whole time, and we figured out about midway through, and I think he might still be here, so I won't mention his name. But that's why I know my mic's coming off whenever I leave the room. So, just from the bio standpoint, and obviously when you're the anchor man, you have to realize what other people said. I think there are important points that I've kind of been taking notes on, that hopefully I can provide a little bit of a summary for the day that goes along with what I am talking about. But I think one of the questions that was asked of me at the lunch was, how did I know I was going to do what I was going to do? I think the only thing was pretty certain for me was going to be surgery. How I got there, exactly what, and that came from heritage. My grandfather was a surgeon back when general surgery meant general surgery. Okay, we've addressed the topic of subspecialization a couple of ways in clinical, both in clinical and research. And there's just no way you're not going to specialize now. Right? I think I agree with many of the speakers that the amount of information that is accessible and we are learning is growing so much. If you guys don't know what Moore's principle is, probably worth looking up. But that's a computer principle in terms of exponential growth, and that's something that we see in medicine. I think it's just going through the roof. We used this example earlier on the day. There was one dopamine receptor when my grandfather was a resident, and that was back in mid-40s, all right? And then there were 5 when I was a resident. There probably, people know more than I do. There were 15 last I checked. So that's just, every time you look, things are changing very, very quickly. I went into neurosurgery, and I'll get into this a little bit, because of some research that I did through a spinal cord injury grant when I was a second-year medical student. So that's actually a little late. Okay, you guys are coming in here through undergrad, already getting very good experiences. But I kind of switched my gears towards neurosurgery about mid-medical school. And I'll talk to you about how that makes a difference or not. I did, as you can see, I was at Howard University for medical school. And then I went to George Washington University, so I was around the DC area for a while before I went down to do specialty fellowship training in cerebrovascular neurosurgery. And I'll tell you why that's important. So we can go ahead and go to the slides, and I'll get into that a little bit more. But the topic that I wanted to talk about with you today is really modern cerebrovascular neurosurgery. And the reason that's important, this is going to be about face for many of the topics you've heard about it, but I think it's really important to talk about how the clinical guy, okay, that's also at a major academic center, really needs to interact with and has realized the necessity of interacting with the basic science in the community. This is UT Southwestern. This is in Dallas. UT Southwestern is the largest medical campus in Texas of the UT Texas state schools. I think there's 500 plus medical students that come through every year. And one of the things that I think we realized probably a little late, there's five Nobel laureates actually practicing there at this point. Now that's pushing it because some of those guys are practicing on walkers, but so there's definitely a basic science community. They are down here, okay? The clinical buildings are up here, okay? And there's a concept in medicine and device and drug development called Death Valley. It's right about in here. Because if I'm coming in at 6 o'clock in the morning and I want to work all day and then have to work at night, do I want to come down here to have a discussion? Not so much, but it's necessary. So now they built a nice little track here. This is Zale Hospital, which is where I work. This is now, well, it's a freestanding neuroscience center that's now in Texas. That's the one in the state. That's a combination of neurosurgery, neurology, psychiatry, rehab that are all here. A lot of our focus is on cerebrovascular disease because there's a lot going on in that right now, and I'll talk to you about it. This is Parkland Hospital. You may hear about that as you get through training. There's a Parkland burn formula that's still throughout medicine and trauma, and that was developed here at Parkland Hospital. That's our city hospital, where I'm also faculty there. So this is Clements Hospital, which is a brand new hospital, and everything's changed and everybody's growing, but that's the everything but neuro hospital that just opened in January, actually. So, I think the important thing today, is I want to, for some reason those slides are off, but I think we'll be okay. But I wanted to introduce, just neurosurgery in general. All right, there's a lot of neurosurgery. A lot of it is going very, very, very much towards what I think some of the concepts were mentioned earlier today. Comments on the training. A lot of you all in medical school, we can talk a little bit about that. I think what some of the things I'll show are really maybe what you thought you needed versus what we're seeing you need to get into a field like neurosurgery. And then really, I think it's interesting to really get you guys understand where we're going with some of these things. So, what is neurosurgery? It's anatomy, it's trauma, it's tumors, it's spine, it's peripheral nerve, it's vascular. There's a lot of different ways, and those are all the components that go into the neurological system. Okay. All right. What we're really doing is looking at we're kind of in a change now. It used to be if it's in there, take it out. Okay. That's the me neurosurgeon type mentality. That can't do that anymore. Okay, a lot of what we're doing in terms of treating aneurysms, taking out spinal cord tumors, this is another type of spinal cord tumor. This is what's called an acoustic neuroma. That's the 7th and 8th nerve complex that's there. We can do that, and microscopic surgery, fine movements, some robotics. Robotics aren't quite yet at the detail of fineness that we need, or size that we need to get into the small cavities of the brain, but it's pretty close. And everybody in this room, that'll be in your future. But we learn this to learn how to treat these different components. And if you can add trauma, but nowadays there's additional fellowship training in those types of specialties. It's really the surgical treatment of neurologic disease. It's one of the youngest surgical subspecialties, relatively speaking, and there's probably only about 3,500 of us. I think last number was 34 and some change practicing neurosurgeons in the country. What's the most commonly treated part of the body in neurosurgery? Anybody want to take a guess? Who said what? Right. Yeah. So you gold star for you, right? So I think a lot of people think it's the brain. I thought it was the brain coming in, right? It's neurosurgery, but you got to feel you go where the money is for a lot of people, right? And there's a whole lot of spine disease in the world, and that's where a lot of spine is being treated. So if you're as an academic neurosurgeon, where I'm at an academic medical center, I'm teaching, I'm doing clinical research. I can select where I want to go. Again, so specialized. But if you're in the community and you see an advertisement for neurosurgery, you're doing about 70-80% spine and about 20% in the head. Okay, so a lot of what's done. What is neurosurgery and how long does it take? After medical school, it's about 7 years of residency. You can go between 1 and 3 years of fellowship, depending on what you do. Again, that tumor, the spine, the vascular, et cetera. But it's really all towards an understanding about how to manipulate the anatomy and the physiology of the nervous system. Okay, my own path was I went to Morehouse College undergrad in Atlanta, Georgia. That was 5 years because I took another biology and Spanish majors. We've heard the travel motif here in the room. I think travel's great. I had a ball. Okay, but the important thing is you're a human trying to treat humans. If you can't be a human, then don't treat them. That's kind of my general rule. And you really learn about different people when you travel and gain other experiences. That training, okay, is, and you probably see most of these slides, but the training is really towards you're going through undergrad, you're going through medical school. There's boards in medical schools, and a lot of times when we look at medical schools, what we're talking about is these step 1, step 2, step 3. Step 1 scores for neurosurgeons are usually over 221. It's decent, okay? It's pretty good, all right? I would tell you the top candidates we usually see are above 250, okay? And these are people who are in U.S. medical schools. These are people who are not necessarily U.S. medical schools, or we say non-traditional. It's the PC way to say it nowadays. So you can see there's a lot more people matching with those scores, regardless down here. Where you're coming from and what experiences you gained early on, like what you all are doing, does make a difference. And I would suggest, just as an aside, learn how to document the experiences that you did. Okay, so just because you did it, if you don't put it on paper the right way, we don't see it and we don't know you did it. Okay, so another thing that you might find interesting is research projects. You always learn as you're going through that, the amount of research is going to get you into your residencies or your training if you're going down the clinical route or the MD PhD route. As you can probably see here, this is the number of research projects. These are the people that matched, again, U.S. and independent. A few, okay? But I can guarantee you, if you come in and say I had 5 research projects or more, but you can't tell me about any of them, you didn't do research, right? So, we've had some good examples of how to discuss and how to talk about what you're doing, and that's, I can guarantee you that's the question that we ask if you're in our field. If you come and talk to me about vascular disease and there's a stroke research that you did, you better know about it because I'll talk to you about it, okay? So, and similar trend here, and I think pretty much everybody in the room is probably pretty safe because we're, I think, mostly U.S. medical schools, right? So, this one I think was surprising, and all this data comes, it says Emory, but it actually comes out of a senior society, which is the group that we take all the data of residents or medical students trying to match. Schools, with NIH funding, okay, there's no offense, but a lot of times you do okay if you didn't have it. All right, if you get in. This one here is Alpha Omega Alpha membership. That's your large, your high grades. Get in. There are a lot of people that didn't have that still matched in neurosurgery. What were they doing? They were developing the contacts. They were doing the research. They were had a lot of energy. PhD degrees. Okay, not necessarily. We've had some discussions about the MD PhD in neurosurgery. It's a long time. Okay, and a lot of people go into neurosurgery. If you want to spend 10 years or 7 years, 8 years, okay, just before you get to residency and do 7 years and expect to do another 2 or 3, that's a lot, and then you better be doing what you want to do afterwards, okay? The last person that I had that was our fellow, he did MD PhD. He was older than I was coming into fellowship, and he went out after doing a Cerebrovascular fellowship and is a spine surgeon, right? So graduate degrees, same thing. So this is not to discount in any way the importance of research, but I think you have to realize when you're getting into residency and you're leading down a clinical career, the importance of your research projects right now, from my standpoint, again, these are my opinions as an educator, are understanding what you're doing, understanding that method so you can apply it to answering the questions that you will answer for the rest of your life, okay? Training has changed a bit, okay? Residents used to just go work, okay? But in a weird sort of way, the public is beginning to understand that when you are, everybody's heard of the art of medicine, right, versus the practice of medicine, right? It's both, okay? And the public is beginning to understand that you as a trainee are practicing, and they don't want to be practiced on, okay? So the more you hear about medical errors and all those types of things, the less the trainee gets to do and interact because of the environment, okay? This has nothing to do with suits, okay? Texas is a state, we don't worry about that so much. No, that's a different story. But residents are really, they're not allowed to be in the hospital anymore. 80-hour work week is a resident work week, and that's twice as much as the normal work week. That's nowhere near what we did before 2003. Okay, so 80 hours is considered a limited work week, and so now what we have to do is figure out as neurosurgeons, how do we train people how to do surgery, okay, but not keep them in the hospital, all right? So I'll show you very quickly what we're doing at UT Southwestern to help with that. I'll emphasize here, because I think it dovetails on a lot of the things that we've heard today, that there's got to be a minimally invasive option. Some way, we're no longer just slicing and dicing, okay? We are now learning how to apply very, very specific concepts, okay? Very similar to what you spoke about in terms of, we can put sub-millimeter pipettes into the brain and change things, okay? With the imaging and the localization capabilities that we have from robotics, from imaging, okay? And if we can figure out where to put things because we understand the physiology, that is what's called, deep brain simulation, but also a functional neurosurgery, okay? And that's a huge field right now, okay? This is just an example. This is a laboratory that we designed and is really recently opened to help train the residents in neurosurgery. And this is, we call it the Clark Sampson. These are the two chairs that were of that department. BioSeals laboratory, but each one of these are actually fully functioning operative stations with microscopes. We use the microscopes now with our mouth, so we can move the microscope around while I'm using my hands. And so we have to, that's another skill you have to learn, okay? And so all this is all set up so that practice doesn't have to do as much anymore, right? You're still gonna do some of it, okay? But we're cognizant of that. Texas just got $120 million put into a simulation laboratory. Okay, and we're still trying to figure out where that money is going to go. Oil prices. Okay, so what is vascular neurosurgery? I'm gonna go through a couple of ideas here, but vascular neurosurgery is what I do. Okay, back in the 1990s, what vascular neurosurgery meant was we're treating ballooning blood vessels or aneurysms. We're treating malformations of blood vessels that are from birth. We're treating these other diagnoses here. It was surgical. Okay, everything that we did in neurosurgery to treat vascular disease was this way, through the head, through the skull. Okay, in 2015, okay, we've added a couple of things down here. Endovascular therapy in stroke is probably 50% of what I do now. All right, I've been in practice now 11 years, and when I started, it was about 30% of what I did. Okay, that is my minimally invasive way of treating patients with blood vessel disease, and what that means is when you had a brain aneurysm in 1990, it's a weakness in the wall of the artery. It could pop or it couldn't, okay? But you get the worst headache of your life. A CAT scan would show blood. An angiogram, just like an arteriogram for the heart, would show an aneurysm, and we would go in there and treat with surgery. When we treated with surgery, what we would do, is there's your bleeding, is we would place a clip across there, and that would block that balloon off. That's what we did in the 90s, okay? In 2015, same thing. We don't do angiograms as much anymore, okay? We do them when we need to, but we do them to treat patients. We're not just looking anymore because the imaging is so good, all right, that we can diagnose based off these angiograms. So a CT angiogram, and now we're treating by surgery or embolization. So now instead of putting a clip across an artery, I take a catheter from the groin. It's like changing a lock from across the street, okay? Put it down into the aneurysm and fill it. Sometimes we have to put stents, very similar to the heart stents. Okay, and we talked a little bit about engineering, bioengineering. It's a big deal now. I've got cousins in medical school that went through bioengineering, okay, to get to medical school, and all of this was engineered to fit in the brain, okay? So this is just a historical perspective to really show you where a lot of this endovascular, going through the groin therapy, has gone. From the 90s to the 2000s, look at the procedures that were going on as the technology developed, okay? This is just a little bit of a look, and that top slide shows the number of aneurysms that were treated at our institution. We're probably treating about 300 aneurysms a year, something like that. And what you're seeing is the ruptured aneurysms and the unruptured aneurysms, but we're also seeing the endovascular and the microvascular. You see everything starts becoming less invasive as the years go on, okay? And that's really, the only importance of this is really to show how minimally invasive techniques in many of the disciplines of neurosurgery, based on our research and based on our understanding of the disease, have gotten more and more common. This slide here is to show that we finally crossed back in 2011 or so. We started doing more minimally invasive procedures than open. But there's a lot of questions in vascular surgery about who to treat, how durable is the treatment when we work from within the groin versus coming from the outside. We're getting to the point in vascular neurosurgery where all the things were before to block off things from the outside with surgery. We're getting to the point where we got to ask, is surgery really necessary? Okay, we've come that far. When I first started in neurosurgery in 1999, every 6 months something was changing. Okay, we're now about every 2 years. Okay, in terms of newer technology coming on. I'll just, again, to show a couple of interesting things that we're doing. The surgery is becoming less and less necessary because that stent that I showed you on the previous slide, which looks like chicken wire, okay, that goes out the vessel. All right, we've now gotten to the point where we can now braid, or robots can braid micron thick wires into tubes. We can pretty much create a stocking that goes inside the blood vessel. Okay, so whereas before we were just using that chicken wire to hold the coils in, okay, we're now reconstructing the inside of the blood vessel. We put you on a couple of medications for about 4 or 6 weeks, and then your blood vessel's reconstructed from the inside. Now there's goods and bads about it, but what that's called is flow diversion. Okay, so it's real easy to take a stent, put coils in, and keep it like that. But if your aneurysm looks like that, where does the stent go? All right, it has to go all the way across here, and then you have to coil around it. Okay, or you can take a very, very fine mesh and build that mesh, all right, to reconstruct that blood vessel. Okay, this is something that went from that aneurysm to that aneurysm, all right, which can turn this aneurysm, which is behind the eyes, that was pressing on the cranial nerves and giving the patient double vision and bad headaches, all right, it can change to that in about 6 months. Okay, so that's a big deal, and that's changed. That's gone. That's really just since 2009 is when it was available in the U.S. Okay, another little tidbit about the travel. One of the reasons that I still travel a bit outside the U.S. is because the FDA here is much more restrictive than the FDA in Europe, the FDA in South America, and the FDA in China. All right, now don't go and tell your Chinese and South American friends that they're guinea pigs. All right, but if you really think about it, in the U.S., we get 5th-generation devices, okay? In China and South America right now, they get first. Just think about that. So, but the only way I'm going to know how to do that, so when they come here, I can offer it to patients because we're at a large center, is to be overseas, okay? So the devices that are available, it's still not all pretty pictures, okay? But those little pictures that I showed you are really revolutionizing what we can do with aneurysm care. And that's really where my research side goes. I'm on the clinical side. I am understanding these patients. We actually, in those laboratories, I've got an angiogram suite also in the lab. So we can actually trial those and see where they're going. Many of my initial experiences with those devices were in rabbits, okay? And we have long-term survival experience for that. I put this in here, and I'll skip through this. Has anybody ever seen this curve? It's called a Gartner hype cycle. Okay, so whenever we go from bench to clinical, okay, we have to go through a period of time where we develop a device, we develop a technique, we treat it, it then becomes available. Okay, it's called a technology trigger. Okay, this flow diversion did the same thing. It was great. We thought it was just going to revolutionize. Everybody was putting those things in left and right. I was a little slower on it. We were at my institution just because we thought we should be. All right, but you get this peak of inflated expectations, where you think everything's going well, and then you start hurting people. Oh my God, I can't believe I did that. Maybe I shouldn't use this device. What should I do? And then we start looking and seeing, okay, now we've got this slope of enlightenment. Now we say, oh, we probably should have done this. Maybe we should have done that. Maybe we should have done this. All right, and then we get to the point where we're probably using it on the right people. All right, and excuse my frankness, but that's just what we do, okay? And you'll see this if you introduce this to many of your other concepts as you learn. This hype cycle happens a lot. You usually want to kind of get it right in here. Okay, so it's real important to select the patients, and I think that's really what that cycle shows. That everything new is not perfect. Okay, and you need to understand the patients that you're treating. I'd be remiss if I didn't put some clinical cases in here. But this is a patient. There's a firefighter who came in. He's 44. He was fighting a fire. He had a real bad headache with his suit on. And collapsed. They thought his tubes were broken. He was inhaling smoke. Turns out he had a pretty significant blood hemorrhage. The aneurysm was right there, and there's actually missed because it's so small. All right, and that's something called a blood blister aneurysm, because pretty much what happens is it looks like a blister on the blood vessel. All right, and those are very, very dangerous because if you go to put a clip on it and you move, it could tear a hole in the blood vessel, and that becomes an issue. Okay, so early on, surgery is what we had to do, and this is what it looks like surgically. And this is more to give you an idea of scale in terms of some of the things we do. That loop, that ring right there is about 2.6 millimeters in diameter. That ring is designed to go on this blood vessel. Okay, so 2.6, 2.8, 3 millimeters is a pretty decent size for the blood vessel. And this was early on when we were doing surgery for these, and what we have to do is put a clip across that blood vessel, but we have to narrow it. Okay. Slide forward. And if you're narrowing a blood vessel in a 44-year-old, what's going to happen when they're 64? Okay, so we're thinking about that when we do that. So what we've done now with those same types of blood blister aneurysms. So this is another lady. It was also not seen, and they actually sent her home. Okay, so this is a lady that came in with still this aneurysm. And what we decided to do, because we had the availability of those stents, okay, this flow diverter, is we placed the flow diverter. And these are images over a period of 3 days, 1, 2, 3. And you can see that slowly start to go away. Okay, so that's changed a very, very, you know, we talk in terms of morbidity and mortality, death and maiming, okay? And that's changed the procedure that probably has a 30% morbidity, okay, to a lady that just walked out of the hospital in 2 days. All right. So this, you can kind of see the stent in there just a little bit. Okay, so there's still some things where aneurysms aren't treated by the flow diversion. Okay, and I use this the video to kind of let you understand what we're doing in terms of the anatomy in the head. These are aneurysms that are in the back of the brain, and the reason I brought the skull was really to kind of give you an idea. Some of the endovascular therapies that we use. If we block off an artery, okay, the endovascular procedure is by placing those coils in, we fill the aneurysm with the coils, clot occurs, and then scar occurs. Okay, if that happens, but we also end up clotting off the other artery, that's a stroke, and we weren't very successful with our therapies. So where there are instances where the clotting is too risky, okay, then the endovascular approach may not be good, and we still have to take them to surgery. So this is an aneurysm called a pica aneurysm. If anybody's looked at their neuroanatomy, that's one of the little arteries that comes off in the back. Okay, so we're working in this area of the brain, the cerebellum. Okay, and that pica aneurysm is very, very close to very important nerves, the cranial nerves as they come down, 9, 10, 11, 12. Those are nerves that control swallowing function, some gastric function. This is a lady who had the endovascular therapy done, and she kept having recurrence of these coils. You see the coils are in the blood vessel there? Okay? And this keeps recurring. So what we had to do was we took her to surgery through a little window like that. So if you're looking at this picture right now, that brain that's being pulled is the cerebellum, okay? And we're working like this, okay? And what you're seeing is that nerve right there is the 11th nerve. That's the nerve that triggers your shoulder. Okay? The artery that's coming out right beside it is the pica artery, which is here. Okay? And this is the vertebral artery, which runs inside of the scalp, and we'll do some pictures here in a minute. But that's the vertebral artery. The vertebral artery, you can't feel like you can feel your carotid. Okay? But it actually runs up through a little hole at the bottom of the skull and gives off the artery. Now what we're seeing, if we move their cerebellum out of the way, okay, now is the basilar artery. These two arteries form, and that artery runs right up the center of the skull, right up that slide of bone called the clivus, okay? So the trick there is to stay away from the cranial nerves that control your swallowing so they don't walk out with a feeding tube, okay? But we also have to work with the aneurysm, and that's the aneurysm neck that's right there. So you can see where it's marked. The coils themselves are actually opening or tinting out the aneurysm, okay? So we have to be very careful to work our way under the aneurysm and then gently take a clip. So what we did in this case, this is the clip, okay? And I'm left-handed, if you can't tell. So And so we're coming with my left hand. That's a clip that I put on there so we can see a little bit further into the deep space. So realize we're working in a space that's about 3 centimeters big, okay? But it's like a cone. Everything we do is a cone because it just goes deeper, all right? And then over time, what we're going to do is I'm going to release that clip. There are coils inside. That's those little coils inside. And so we're going to kind of take that clip, pull this artery down. That's the pica artery, okay? And then slowly kind of march my way in so we can block off the aneurysm, but I have my suction as deep as I need to go, so I'm telling myself where I need to go, okay? We talked about the laboratory and working with the microscope and using the mouthpiece, all right? You can see both hands are moving, but every once in a while you'll see the scope kind of go in and out, okay? And so what I'm doing there is moving the scope so I can get good focus as I'm going deeper into this space, okay? So this is slow and hard to watch for me too, so I'm going to move forward here, but I'm just kind of marching that clip in until we get it finished, okay? So that's an example of aneurysm surgery. That's probably aneurysm surgery that's done more often now, okay? Because a lot of what we're doing now goes through the groin. The recovery times are better. But a place that's really been revolutionized in terms of the cerebrovascular world is stroke, okay? Stroke in the 1990s, the neurosurgeon was like, good, stroke, call neurology, okay? The neurologist said, good, give him an aspirin, see you later. That was it. That was 1990 stroke, okay? This same thing, TPA came along. TPA is a drug that we can give. Those are the clot busters that you hear about all the time, okay? And in those clot busters, they would open the blood vessels up, but if you didn't get to the hospital fast enough, you still had an issue, okay? Came along back in everybody's here is probably too young to remember ER, okay? But in ER back in 2004, they actually had an episode of ER where this, what's that show, Sex and the City? Probably too young to remember that too, but there's a redhead in there, and she was one of the actresses from that. She comes in, she has a stroke, and they did the entire episode from the viewpoint of a patient who had a stroke, okay, that all of a sudden got this little corkscrew put in her blood vessel, took the clot out, and she woke up on the table. That was the whole episode. That's the first time that there was ever direct marketing by TV of a medical device, okay, and that was this Mercy device is what it was called. We got great names for all this stuff, okay? So Mercy's dead. Mercy died within 4 years because that technology got more, okay? So the next thing that we did with stroke, because now we're able to access and get into the blood vessels, if you got a corkscrew doesn't work, why not use a vacuum cleaner, right? All right, so they did a real special medical vacuum cleaner, and we took all these catheters, and what this catheter was designed to do is go into the clot, and then you move this little thing back and forth called a separator. That munches the clot up while the vacuum cleaner's on, okay? And that sucks the clot out, and that changed our ability to open up blood vessels. It was very, very successful, okay? Dead, all right? That was dead by 2000, more recently, okay? So, and all that's dead because now, okay, remember that chicken wire from the stents that we used to use? All right, somebody had we used to take those stents and use the same stents for the aneurysm, but put them inside the blood vessel with the clot in it. So we put it out halfway, we'd open it up, we'd clear the clot out, and then we'd have to leave the stent because it wasn't attached to a wire. So somebody had the bright idea, well, let's put the stent on a wire so we can put it out, open blood vessels up, and then pull it back in and take it out, okay? And what that's called is a stent retriever, and that stent retriever has changed stroke. So look at the date on that, January 1st, 2015, okay? So January 1st, 2015, they had 4 studies come out pretty much all within a month that said if your patient comes to the hospital and you use those stent retrievers, it changes the way that the patients can do, period, done. So we talk about stats, statistically significant, okay? And so right now what we're in, the world of stroke and cerebrovascular disease, is we can do this now. Okay, and we can open up the blood vessels very, very fast and get patients as long as the patients come to the hospital in time. It's very possible that at one point we're not going to, the TPA is going to be dead. Okay, because now we have to get in there. So the data is that good on that. Now, of course, I think frequently we're very pessimistic. All right, neurosurgeons, I think we're optimistic in general because we deal with such bad disease, okay? But now can you imagine that people are actually arguing that, why are you telling us we can only use stent retrievers, we want to use TPA? If you get the irony in that. So we go through all this fighting to get this good device, and now the insurance companies are saying you can only use the device, you can't use the medicine. It's a very clinical world. We can take, this was a young patient, she was 18, she had a bad headache at school, went to the school nurse, and the school nurse wasn't real sure how she was doing, so the school nurse sent her home, didn't tell her mother, and mother came home and found her pretty much, on her way out, okay? 13 hours later, we were able to open that blood vessel up, all right, and she walked out of the hospital. That's what we can do now, okay, with cerebrovascular disease. But a lot of it, and what we're really trying to figure out with cerebrovascular disease is now we can do these things, okay, technologically, but who are we supposed to do them to, okay? So that's where the imaging comes in, reactivity of blood vessels. A lot of the neurophysiology we need to understand so we can select patients better for the procedures that we have. And that's where we have to kind of cross that north to south bridge, okay, and have the clinical physicians speak, the academic clinical physicians speak with the research teams and decide about the questions. I think generally in what is neurosurgery, vascular neurosurgery is really the application of those techniques to really address complex vascular problems. It's a really good field for patients who, or for people who love tech and engineering, computers. I got screens all over my desk and I like doing this type of stuff, okay? It's, stroke is now what we do a lot of, okay? And it's gonna be different in 10 years, there's no question about that. A quote I like to finish with, I think, I honestly forget who this came from, all right? But man is really the only creature who has outthought his hands. We are beyond our hands at this point, okay? And a lot of what we're doing now is trying to figure out how to use our brains to treat our brains, okay? I'll finish with a couple of things just from listening to the talks today. I think the whole concept of subspecialization has come in, both clinically and I think also from a research standpoint. I think I want to emphasize it's real important to be a doctor and not a technician, okay? You're treating people, okay? And whatever we do is going towards treating people, regardless if we start with a rabbit or a rat, we're still getting to the point where we're treating people. I think that's important. I think there's really been a significant change in the concepts of plasticity. I started when, the brain was not going to get better after a certain age. We still throw around this mantra of once you get beyond 6 years, you're not going to change anymore, all major things. And I think it's pretty well understood at this point that that's not the case, okay? And we're learning how to manipulate that physiology a lot better. The final point I think that you've probably heard multiple times is communication is key, okay? When you have, you don't have to learn how to do everything, okay? You need to learn how to do certain things pretty well and then find the other people who do the other things very well and form a team, okay? That's the only way that we move concepts forward, I think, right now, because there's so much data that we have to manipulate. So if I take that last little piece there, and I'd be happy to answer any questions about what I've talked about. So thanks for listening.